Hi guys, so another diary entry for today. So I did one earlier this morning, like 5 o'clock, and it's already almost 4 o'clock, and I just got back from internal med, and I had family medicine as well after that. So I've had my first clinical skills session for family medicine. For internal medicine. And I just want to summarize what we've done today in class. So today for clinical skills for internal medicine, we did some components of the BLS, which we did in clinical skills too, if you remember. So we went over like the basics of BLS. So we talked about the general approach. So the algorithms. So danger response, circulation, airway, breathing, and defibrillation. So it's the way I remember it is Dr. Cab and then D at the end for defibrillation. So Dr. Cab, D is for danger. So we assess the environment. If it's gonna put us in danger, obviously we don't go to that environment. If there's fire or something, if it is like a danger for the patient and you can't do CPR there, then you move for instance, you're in the middle of the road, then you move the patient or the victim somewhere else that's not in the middle of the road, maybe like along the pavement, or like get other people to block the way so you can start CPR. So R is for response. So we check for responsiveness. So we do this by providing two types of stimuli. So we do tactile and verbal stimulation. So tactile is you like touch the patient, shake the patient, and verbal, you say something like, hello, can you hear me? Are you okay? Just something to elicit like a response. If they're unresponsive, the next thing to do is call for help. Before you check pulse or anything like that, if they're unresponsive to those two, the tactile and verbal stimuli, call for help. Or ask someone to call for help if there's a bystander. If there's someone there with you, just ask them to call for help. And then the next thing is C. So C is we check the circulation. So for adults, we check on the carotid. So we locate the cricoid cartilage, and then we go sideways from there to check for the carotids. So if the victim is like, if for example I'm the victim and then the person is on my right, the rescuer is on my right. So what the rescuer needs to do is to put two fingers on my cricoid cartilage and move sideways. So the rescuer has to be able to see the two fingers. The rescuer shouldn't do this, okay? Because this might obstruct like the trachea or something. And the lecturer explained that when you just when you just become unconscious, there's gonna be some residual air, and you might feel that, and you might mistake that for a pulse. So do it on this side where you can see what you're doing. When you can try, see, and feel for the pulse. Okay. So the next one after that is we talked about circulation a lot in this session. So that's for adult. For child, you can check on the brachial, and it depends on the age of the child. If the child is 12 years old, then you can check the carotids and brachial. If the child is like an infant, they're so cute. They have lots of fat in their neck, so it's not really appropriate to check for carotids. So in an infant, you check maybe on the brachial and the femoral artery as well. And then you check the pulse for maximum. You count 1 to 10, and if you can't feel a pulse, like after counting 1 to 10, then there's no pulse. Don't wait any longer than necessary. Okay. So if there's no pulse, so you do that. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. No pulse detected. You start CPR. So in terms of placement, so what we do is we go on the patient's side, the victim's side. We don't go on the head bit. We go on the patient's side. And then we locate so we place this bit of our what do you call this, palm, wrist region, on the lower third of the sternum. Okay, not on the xiphoid process, just the lower third of the sternum. So in males, this can be located by finding the nipple line, and it's along that line. For females, obviously, because of different like sizes of breast tissue, you know, if it's an elderly female, their nipple line might be all the way down there. So what you do instead is locate the xiphoid, the sternum, which is the end of the sternum, the xiphoid, and put two fingers above the xiphoid and place that surface of your palm there, okay? And you try to do it with straight arms and like lean like over the patient. You don't, it's hard to show you guys, but you know what I mean. We did this in CS2. So you position yourself properly, you do it with arms fully extended and arms, what do you call it? Palms interlocked, not palms, hands interlocked. And it's this that's making contact with the lower third of the sternum of the victim. In terms of rate, it's 100 to 120 compressions per minute. And is there anything else I missed? So in terms of compression to ventilation ratio, it's 30 to 2 for adults. It doesn't matter if you have one rescuer, two rescuers, 10 rescuers. It's always gonna be 30 compressions to 2 rescue breaths for adults. For children, it's different. So for children, the ratio is 15 to 2. And the reason for this, so the reason why we give them more breaths per number of compressions is because for pediatric patients, the most common cause of cardiac arrest is respiratory failure. That's why we need to give them more breaths per compressions as opposed to adults. In adults, the most common cause of cardiac arrest is something of a like cardiac or cardiovascular origin, okay? So we need to, after doing 30 to 2, we reassess the patient's condition. My laptop's dying. We need to reassess the patient's condition after 2 minutes. So after 2 minutes, if we do this like with perfect timing, so if we give compressions at the rate of 100 to 120 compressions per minute, and we're efficient with giving rescue breaths, within 2 minutes we should have done at least 5 cycles, so 5 to 6 cycles of compression to ventilation, usually 5 cycles, and then after the compressions we move on to our A. So A is airway. So after doing 30 compressions to after doing the compressions, we check the airway. So for airway, we're looking for any obstruction. So we tilt the patient's head to the side, and if we can see like a visible obstruction, then we do like the hooking technique. Remember from CS2, we hook it out to the other side. We don't do any blind finger sweeps because this risks pushing the object further down into the patient's airway. If it's like blood or secretions, we can use like some tissues and we can try sweep it out, okay, of the patient's mouth. Obviously, if we're in the hospital, we could do suctioning. And if we're also in the hospital, we could use some tools or some instruments, I guess you can call them, to help us maintain a patent airway. So the most common reason for a blockage in the airway is the patient's tongue kind of blocking the airway. So what we can do in a hospital setting is get like an oropharyngeal airway or a nasopharyngeal airway. Oropharyngeal goes from the mouth down, and then nasopharyngeal goes from the nose down to the airway. So what this will do, the oropharyngeal airway, it's gonna like, it's gonna push the tongue out of the way to make that clear lumen for ventilation for the air, so that the tongue is not gonna be like blocking or covering the epiglottis. It's just to be able to deliver like effective ventilation if the tongue is out of the way. So that's something we can do in the hospital, but obviously not always possible in just, you know, a normal public setting, unless you're carrying an oropharyngeal airway in your pocket 24/7. So also we need, because of pandemic times, she made this really clear. It's actually not advised to do like mouth to mouth breathing into someone because of the pandemic. So what we can do is called unsynchronized CPR. So unsynchronized CPR just means you're just delivering compressions. You're not doing any rescue breaths. Okay. So the next part is so we've done checking danger, responsiveness, circulation, airway. The next one is breathing. So for breathing, again, if we're in the hospital, we can use an ambu bag, and we place the ambu bag like on top of the patient's nose and mouth, and we need to make sure that we seal it properly using, I don't know what she calls it. It's like a C&E method. So you kind of, it's hard to show again. C&E method. It's just to like create like a seal, okay? Just to create a seal on the patient's like face, so that the mask bit of the ambu bag actually holds, and make sure that there's no leaking. No, there's no air that can leak out. So you're delivering really effective breaths from the ambu bag. So with that, we need to make sure that we're giving effective rescue breaths. So each person would have a different lung capacity. So I'm very small. So my lungs are probably small as well. And someone who is like a 6'5" person, you know, rugby player would probably have like twice the amount of lung capacity as I have. So it really depends. There's no, there's no specific volume or amount of air required to be pushed to someone's airway when they need some help with breathing and ventilation. So the way we can tell that we're giving sufficient ventilation is to watch for their chest rise. So if their chest is rising, like if you see their chest rising, then it means you're giving enough air to the patient. So obviously there's a risk of hypoventilating them, so not giving them, enough, like not giving them effective rescue breaths. If their chest is not even rising, then you're definitely not giving them effective rescue breaths. You're not giving them enough air. There's also a risk of giving them a lot. So so this can be easily done, like in the practical, especially the guys. I don't know, I think they just push the ambu bag really, really quickly and really aggressively, actually. So what this does, it really inflates the lung of the mannequin. And in real life, this is dangerous because this is called hyperventilation. And in a physiological setting, if we're hyperventilating, it means that we're getting rid of a lot of CO2, correct? And when we get rid of a lot of CO2, we decrease the carbonic acid being dissolved in the blood, and therefore we increase our pH, and this can lead to respiratory alkalosis. So this is one of the reasons why we don't hyperventilate the patient. We don't give them too much of the air, okay? The next reason why we don't hyperventilate the patient is because the pressure from the ambu bag, it might actually, I just turned off. It might actually cause like barotrauma. The third reason why we don't hyperventilate the patient, or we don't push so much air from the ambu bag, is because if you do that, what tends to happen is that the residual air just goes down to the stomach. And if air goes down to the stomach, it might push some of the gastric contents out from the esophagus, then out to the mouth, and this may cause aspiration. So the patient might aspirate on the gastric contents that is being expelled because you're pushing a lot of air down to the stomach. The last reason is because it's related to that stomach as well. So if you push a lot of air into the patient's stomach, it increases the pressure in the stomach, right? And the stomach is on the left side. So what tends to happen is it inflates, and it has a lot of pressure which pushes up to the diaphragm and causes increased pressure in the thoracic cavity inside the chest. If you increase pressure in the thoracic cavity because you're pushing the diaphragm up, what happens is that the chest wall itself, the pressure inside increases. So you're creating some high pressure environment. It's gonna be rigid. It's gonna be, if there's high pressure there, it's gonna be even more difficult to actually pump air in because there's such a high amount of pressure you need to overcome. So it's gonna be even harder to push air in if you have a high interthoracic pressure. So those are the 4 reasons for not hyperventilating. So again, the first one is respiratory alkalosis. The second one is barotrauma. The third one is aspirating on gastric contents if you push a lot of air in the stomach. The third one is increasing abdominal and interthoracic pressure, which makes it difficult to pump air in to the person's lungs. We also spoke about the total duration of CPR. So the total duration of CPR should be 45 minutes. And after 45 minutes, you stop. Obviously, there's some exceptions to this. So if there's no recovery after 45 minutes of trying to bring this person back to life, we can confirm biological death if we see a systole on the AED or like the monitor thing in the hospital. We cannot confirm death after 45 minutes if the patient is still showing VFib or VTAC. Okay? We cannot confirm death if we still see on the monitor or the AED that the patient is in VFib or VTAC. In this scenario, we carry on beyond 45 minutes. Other 2 exceptions in this 45-minute max CPR rule is if the victim is a drowning victim. So if the patient has like drowned, especially in cold water, and the second exception is if the patient is like a victim of like electricity, so like from electrical trauma. Okay, so again, the 2 exceptions: electrical trauma and drowning, especially in cold water. So in these situations, we try a bit longer, past 45 minutes. Okay, so just going back, so danger, assess for danger, and then response, and there's no response, we call for help. We check their circulation, and there is pulse in this scenario. This is the second scenario. There's pulse, and we check their airway, no obstruction whatsoever, and they're breathing, but they're not breathing. So for breathing, we can look, listen, and feel. So we look for chest rise. We listen if we can hear like breath sounds, and we feel if there's any like air being expelled out of their mouth. You'll feel that it's warm if they're breathing. So if there's none of that, it means the patient is not breathing. So this is a possible scenario where there is pulse but there's no breathing. But you can't have it the other way around. You can't have breathing but no pulse. That doesn't happen, because you can't have that, because the reason why the lungs stop is because you're not perfusing the brain, because the respiratory center is in the brain. So if you're not perfusing the brain enough, then it's gonna shut off. So it's not gonna be able to send impulses via that respiratory center in the brain for your breathing muscles to do the work. So you cannot have a situation where someone is breathing but there's no pulse. No, that's not possible. But it is possible, however, for someone to not breathe, to not be breathing, but have a pulse. So this is the second situation. So you've done the danger check, responsiveness check, circulation check, and you feel that there's pulse, and airway check, there's no obstruction, and breathing check, the patient is not breathing. So in this scenario, what you do is you just give rescue breaths. You don't do CPR. So for rescue breaths, the rate is 10 breaths per minute for adults, and for children, it's 12 to 20 per minute. And with giving rescue breaths, you need to make sure that you don't squeeze the ambu bag too quickly. You deliver it nice and, like, it's not very slow, but nice and slowly, just like a normal breathing. And you watch for their chest rise. That's really important. And again, we don't hyperventilate the patient. So I think that's everything for today from the practicals. So I'll keep you guys updated for the next few practicals.